This is continuation of acid-base disorders. Here we are discussing anion gap and non-anion gap metabolic acidosis. So first, anion gap metabolic acidosis. There are four main reasons. First is poor tissue perfusion, that is lactic acidosis, which we see very commonly in our clinical scenarios. Then diabetic ketoacidosis. Then renal failure, where uremia causes the metabolic acidosis, and methanol and ethylene glycol poison. So the normal anion gap is taken as 10 to 40. So the anion gap is calculated as sodium ions minus the sum of chloride plus bicarbonate. Now, potassium we don't use in the anion gap calculation uh, basically. So because potassium is mainly intracellular, and so mainly in the positive ions we use sodium, and in the negative ions the main two primary anions in the body is chloride and bicarb, which are maintaining the electronegative balance. So we are using them in the calculation of anion gap. So non-anion gap metabolic acidosis. So as we have seen, bicarb and chloride are two predominant anions. So they are in inverse relation to each other to maintain the electronegative balance. The other unmeasured anions are proteins, phosphate, sulfate, and citrate. So the three main causes of NAGMA is first is severe diarrhea, where there is loss of bicarb from GI tract, and renal tubular acidosis, where there is loss of bicarb from kidneys. So here, the main thing that happens is loss of bicarb. So there is increase in serum chloride to compensate this loss of bicarb. So there is hyperchloremia. Okay. Now the third cause is excessive infusion of normal saline. So there is hyperchloremia. Now again to balance this hyperchloremia, there is intracellular shifting of bicarb. So there is decrease in the serum bicarb, which leads to non-anion gap metabolic acidosis. So thus in all these scenarios, we see that there is hyperchloremia. So that is why non-anion gap metabolic acidosis is also known as hyperchloremic acidosis.